I've been given the mandate to speak on the role of urodynamics in female urinary incontinence. And so I will be restricting myself to invasive urodynamics in this talk and all the additional maneuvers that go with it. Now, if you look at the clinical diagnosis of urinary incontinence, our ability to make a diagnosis and our ability to exclude a diagnosis, both are reasonably good, perhaps with the exception of our ability to exclude a diagnosis of urgency incontinence. And because of this fact, and the fact that there's low potential for harm with most conservative therapies, as a general principle, invasive urodynamics is inappropriate before non-invasive treatments for female urinary incontinence. And this is my first key message of the afternoon. Now let's look at some of the classical findings in urodynamics. And to clarify, the top tracing here is P vesicle in blue. The second trace here is P abdomen, the rectal pressure in red. And the third trace is the one that we are truly interested in, the P det. And you can see as the bladder is filled up, you get a phasic contraction. And with that phasic contraction, you have incontinence. And so this is detrusor overactivity incontinence. Subsequently, in the same cycle, as the bladder is filled again to about 200 ml or so, you can see coughs, graded coughs done for this patient. And on a cough stress test, you can see there is no detrusor contraction. Initially, this woman does not leak. But then when she's made to stand up and the urethral catheter is removed, at that point, you can see that she leaks. So she does have urodynamic stress incontinence. And what this also tells you straight away is that to be able to unmask stress incontinence, you might need to make the woman stand. And in fact, you always examine in the standing position all these women. And you might need to remove the urethral catheter because some women do not leak with the catheter in place. Remember, you must zero your transducers during the test to the atmosphere, not to the patient. Now you might ask, how does it matter? Because ultimately P det is the subtracted value. But if you are looking at the leak point pressure, your leak point pressure will be underestimated if you have not zeroed to the atmosphere. So remember, zeroing of the transducers has to be to the atmosphere. So when you start the trace, the test, there will be some finite value of P abdomen and P vesicle, and they should subtract well on the P det line. So what about surgery for uncomplicated incontinence? Now, all the guidelines based on certain studies, which I'll just come to in a moment, state that you do not really need to do invasive testing for the uncomplicated woman with stress urinary incontinence, whether it's the EAU guideline, the Urological Society of India guideline, all the guidelines state this. And what's the reason for this? This is based on a systematic review which showed primarily from these three studies, and especially the value trial, which had the highest weight in this study, in this review, that in comparison to office evaluation alone, the addition of urodynamics did not improve either the subjective or the objective outcomes. But it's important to understand this in a little bit more detail. Now, if you do a careful scrutiny of the value study, what you find is that there were highly select criteria for inclusion. So select, in fact, that 2/3 of women who had stress incontinence did not get included in the final analysis. In fact, only 13% of the original cohort of women who were screened got into the final analysis, the intent to treat analysis. This research was carried out at highly academic centers. And in contrast to all the other studies done by the UITN group, all of which have both objective and subjective criteria as their primary outcome, this was the only study that I can recall from the UITN group where the primary outcome was only subjective. So if you look at it carefully, there are certain limitations to the value trial, and I leave it to you how well this would be applicable to your individual practice. A bigger issue perhaps is in defining uncomplicated. And this is something surprising because if you look across various guidelines, there's no clear single definition of what uncomplicated constitutes. This is the EAU definition, which I accessed day before yesterday. A woman with uncomplicated SUI, this means no history of previous surgery, no neurogenic dysfunction, no genital prolapse, not considering pregnancy. That's it. Look at the USI definition. It's a far more arduous definition. There's a far more detailed definition, a lot more additional things here, especially two things additional in the guideline definition: a low post-void residual and a requirement for having scrutinized the uroflow. And we'll come to this in a moment. And the AUA guideline, which uses the term non-index and index patients, which includes advanced age, high BMI, incomplete emptying or high PVR, in addition to the other criteria. But you can see there's no uniformity in the way we define uncomplicated patients. So look at this patient who has clinical incontinence, denies any history of voiding difficulty, has a negligible post-void residue, and apparently a normal flow. And you can see here, this flow rate is normal, but all of you are experienced people at Urodynamics. You can see here, this is not a normal pattern. And if you were to compare it with a normal pattern, you can see that the flow drops off, and this is certainly not normal. And if you look at her Urodynamics, she voids primarily by abdominal strain. And not just that, the moment there's that additional small amount of resistance because of the urethral catheter, her residual goes up dramatically. And she does have stress incontinence. So she would, in a loose sense of the definition, fit in with the uncomplicated patient, except when you were to scrutinize this flow trace carefully. So what I'm trying to imply here is that it's important to make a careful scrutiny when you apply the definition. Now remember, the guidelines have recommended, that patients who do not have voiding dysfunction, compared to those who have voiding dysfunction on the Urodynamics, there doesn't seem to be a difference in their outcomes based on the value trial. And this difference was not statistically significant, but it almost became very close to becoming statistically significant. Remember, this was not powered for this particular purpose to look for voiding dysfunction, the value trial. It was a post hoc analysis taken at face value by all the guidelines. So be careful when your patient actually has some element of voiding dysfunction. These patients may not do that well. So my second key message of the day is exercise diligence in labeling a patient as uncomplicated. There may be significant harm from inappropriate surgery based on the loose application of the definitions. And at the bare minimum, you must have a careful questioning for symptoms, look at voiding domain scores, check the post-void residual, exercise stringent thresholds for what you regard as acceptable void percentages, look at the flow pattern, not just at the rate. And when in doubt, go proceed with the Urodynamics before you do your surgery. What about complicated patients? They account for, with the complicated patients, almost 3/4 of patients will actually have abnormalities in the Urodynamics. And remember, the uncomplicated patients in most series is actually the exception rather than the rule. So it's important to differentiate. And for these complicated patients, you must always do a Urodynamics before surgery. Now, what other findings could you find? You could get detrusor overactivity. And we know that preoperative detrusor overactivity may be associated with persistence of urgency postoperatively, and in fact, high pressure detrusor overactivity may be detrimental in terms of outcomes, especially in terms of urge scores in these patients, which can be more bothersome to the patient than persistent stress incontinence. So the stress incontinence specific outcomes are not different, but patients may still not do as well because they've got postoperative urgency. You could also have cough-associated detrusor overactivity, and this can take several forms, as we published in 2019. And some of these things are difficult to differentiate. So you can see here, this is a patient who has a type 2 cough-associated detrusor overactivity incontinence, where the leak happens with the stress rather than with the phasic contraction. This is a patient who has type 3, where the leak is both with the stress as well as with the phasic contraction. Very difficult to differentiate all these and offer appropriate surgery to the patient just on the basis of clinical history, unless you do a careful examination of the urodynamic traces. The other important finding is intrinsic sphincter deficiency, and we know that patients with ISD have a higher failure rate with surgery as compared to patients who don't. ISD has been defined in various different ways by the abdominal leak point pressure, by the maximal urethral closure pressure, and by the clinical test of the empty bladder supine stress test. But each of these three things tells us a little bit of a different quality about the patient. They're not really comparable. Each of these definitions for ISD yields a different patient subset. But we do know that these patients tend to have a higher failure rate. It's possible that a retropubic procedure may give a better outcome, but because there's only one randomized trial, at least to my knowledge, by Skierlitz et al. In 2012, we don't have a good body of evidence to show that the transobturator approach may be less successful as compared to a retropubic approach. What about urodynamics for urgency incontinence? In patients with urgency incontinence, there does not seem to be a difference in outcome based on whether the patient has or does not have phasic contractions during the urodynamics. And hence, most guidelines suggest that before proceeding with invasive testing or labeling your patient refractory, you don't need urodynamics. Except our guidelines, the USI guidelines, which makes a weak recommendation for doing urodynamics, not because we want you to search for detrusor overactivity, but because alternate diagnosis, especially voiding dysfunction, is not uncommon, and there is significant potential for harm because once you label the patient as refractory, it opens the floodgates for treatments like sacral neuromodulation and botulinum toxin. And we felt, based on the evidence available, that it would be preferable to have urodynamics. But most of the guidelines do not require that from you. Urodynamics is used very variably by the Urological Society of India fraternity, but as suffice to say that for the complicated patient, you must always be doing it and exercise diligence. So the key message, my last key message of the day is with regard to quality. There's clear problems with quality control in urodynamics, even across the best of the academic centers. It's very important to give enough detail to the technical aspects and the clinical interpretation of the urodynamics. And I'll finally leave you with a little bit of philosophy. Over the last few years, there's a strange dichotomy in our thought process. There is increasing anguish about the harms of invasive treatments of urinary incontinence. And yet at the same time, we seem to be reducing our benchmarks for preoperative evaluation. I think this is something that we need to resolve. We need better quality research, perhaps, which is more externally applicable to all our regular centers, not just to the most academic centers from across the world. With that, I will end my talk, and I think we're taking questions at the end of the session. Thank you very much. Back to Arjun.